Hello, everybody. I'm not used to doing a webinar, so it's kind of strange that I can't. But you're very welcome, and I hope you find today's webinar interesting. So my name's Fiona Lobban, and I'm a clinical psychologist, and I work at Lancaster University in the UK. And today I just wanted to spend a bit of time talking to you about patient public involvement and sharing some of the work that we're doing today. So can we just do a slide, next slide?
Yeah, so we're going to share a slide to start today.
Oh. Okay, great. Okay, so basically what I'm going to do is talk for about 30 minutes. I guess the first thing to flag is that this I couldn't find a good picture of the pond. So this is actually Lake Windermere, which is close to Lancaster University and close to where I live. So this is just to flag up what a beautiful part of the world it is. And if any of you ever come across there, you're very welcome to come and visit us. So I'm going to talk about some of our ideas for about 30 minutes, and then I'm hoping that we can open up for some discussion. In particular, I'm interested in kind of similarities and differences between things we're doing in the UK and things that you're doing in Canada, and maybe what we can learn from each other. So this isn't going to be a strongly academic talk, because obviously I'm visiting the BC Support Unit, which is the Centre for Excellence for this kind of work. And so I really don't want to teach any grannies to suck eggs. So this is very much a kind of personal perspective about sort of the things that have really struck me and that I've struggled with over the many years of working in this area. And before we start as well, I just wanted to say a couple of things about language. So I'm going to use the term public patient involvement, which is the kind of language that we use in the UK for what I think is what you call patient-orientated research. So the public patient involvement is defined as research carried out with or by the public, rather than to, about, or for them. And I think the other area in which the language differs slightly is we often use the term service user rather than patient. And I think this is probably most specific in mental health, where there's a lot of debate around terminology. And it also reflects that most of the work that I'm going to talk about is working with people who use mental health services, but obviously there's a big group of people in the general public who don't. Okay. So I think another important point of clarification, and this is really the first point of learning from my point of view, is that people often quite rightly point out that everyone is a patient. So what do we mean by public patient involvement? And actually, I think what's important here is not everybody is at the table in that kind of role or wearing that particular hat. So in my experience of healthcare research, many people actually have personal experience of the condition that they're researching. And this is not surprising, because generally we're interested in things that are personally salient. And this is, I think, is certainly true in mental health. But actually, when we come to the table and we're wearing a particular hat, it communicates to people what we're happy to share. But it does cause some challenges. And I think one of the things that I'm curious about is this dichotomy that we've set up between people as patients and people in other roles. And actually that can lead us sometimes to ignore the other skills of everyone at the table. So we ignore the lived experience of the researchers, and similarly we often ignore really valued skills of those who are there in a patient role. Example, we've had a statistics professor as one of our public patient involvement people. And I guess it kind of begs the question of whether that dichotomy is helpful, or whether there are some advantages to bringing people to the table and thinking about what experience they have. So just to give you a bit of background about the work I do. So I co-direct So I'm co-director of the Spectrum Centre for Mental Health Research, and we've been going for about 11 years now. And we were one of the first centres to employ a service user researcher as a substantive post within our unit. And this is increasing practice now across the UK. So just to give you a bit of background about what we do. So our goals are to understand lived experience of mental health problems. And primarily we work with bipolar disorder and psychosis to develop novel psychological interventions that support people with these conditions, to evaluate their effectiveness, and to look at their implementation into NHS or National Health Service services and beyond. And actually, the PPI that we've done in our unit has evolved quite a lot over the years and has been informed by some really useful guidelines and frameworks, which I'm just going to share some of these with you. And I just wanted to flag that actually since I've been here, I was having a look at the BC Support Unit website, and things like there was a patient engagement and research scale that was promoted on there, which looked really interesting. And I think it made me think about how quickly this area is moving forward and how new frameworks and new tools are being developed all the time. So in the UK, I'm sure you're all familiar, or maybe you're all familiar with Involve. So Involve is funded by our National Institute for Health Research and has a really useful website where they promote lots of tools and frameworks for patient-public involvement. And also various guidelines. And one of the ones that's been particularly useful for our work in Spectrum is about paying participants. So this has been a huge debate, and I understand is also a debate that continues in Canada. And when I first started working in this area, there wasn't any guidelines for this, and it caused a lot of difficulty. Some people paid participants, some people didn't, people paid different rates. So I think having a framework and guidelines has been incredibly useful from that point of view. Another area that I think is really important that we think about carefully, and I just wanted to flag these particular guidelines, is about how we report the public patient involvement that we're doing. The reason that this is very important is if we want to improve public patient involvement, then we need to understand exactly how it's being done. So for example, if you wanted to do a meta-analysis or a meta-synthesis looking at combining data from across lots of studies to explore how different approaches to PPI have led to different outcomes, then that's only possible if the way in which the PPI has been carried out is reported really, really clearly. And that's the only way we can really learn in a sort of meta sense from across all the different studies. So this guideline, it was developed by Stanisławska, whose name I can never pronounce, and it's part of an international group. They're based in Warwick. And I've just flagged the short form here, but the long form actually is really helpful in thinking through how to write up PPI in research projects. So that's another thing that we've been using. And more recently, I mean, some of these may already be familiar to you, so please bear with me all if they are, but if they're not, I'm just flagging them so that you can see some of the things that we've drawn on in Spectrum. So this one is the Envision Plain Language Summary Toolkit. And the aim of this is to support the writing of plain English summaries for all research papers so that research is much more accessible to the public. And this was really developed because now high impact journals, particularly in medicine, are requiring good quality lay summaries. And actually, academics are generally very, very, very poor at writing them. So this includes a template for the structure and content of the plain language summaries, a quality check for plain language summaries that you're writing, and a cover sheet to help patient reviewers with key information about the plain language summaries to help them to review them. And although it's been designed specifically for pharma trials and therefore not so useful to the work that we do, we're actually looking at how can we adapt it for looking at interventions that are non-pharmacological, so psychological interventions. Okay, and I think this is another area that we don't do particularly well at the moment. It was one of our aims in Spectrum was to make sure that all the research that we produced was also written in parallel for a user-targeted journal or publication. And actually, we haven't been particularly good at doing that, partly because of time and resources, but I'm hoping that this kind of tool might be able to help us to prioritize that and do that better in the future. And I guess the other just thing to flag on that is about the importance of plain language summaries for grants. So increasingly you have to provide the plain language summary for grant applications, and it's a key part of their assessment and allocation of funding. Okay, so this slide is a slightly over-enthusiastic slide, which is an attempt to try and explain how we do PPI in Spectrum. So I'm just going to talk you through it, and hopefully it'll make sense. Okay, so if we start in the middle, in the blue circle, we have a core team, which is a multidisciplinary team of psychologists, nurses, PhD students, researchers, and a service user researcher, and who at the moment is called Chris. And Chris coordinates a lot of the PPI across the centre. So the first thing that he does is he chairs the Service User Advisory Panel, which is the rectangle at the bottom. And the Service User Advisory Panel is a group of about 20 people who meet on a regular basis. And really, the idea of that is to help us to think strategically about the work that we do in Spectrum. So to help us think about what kind of areas we want to focus on, and what kind of direction we want to go in. It's also used more ad hoc for people to run novel ideas past, so new research ideas. Is this a good topic that we should be researching? PhD students share their ideas, etc. And then for each study, so I've given you an example here of 4 studies that we're currently running in Spectrum, and the blue oval-shaped things are each study. So if we start with the recovery trial, which is in your bottom left-hand corner, what you'll notice is that for each study we have a co-applicant on the grant who is a service user, and they become part of the core team when that grant's running. In addition to that, each of the studies has a green blob, which is called a SURGE, so that's a service user reference group. And that's set up specifically for each study and involves patients who have a particular interest in that project. So they may come from the Service User Advisory Panel, but they will also come from, more broadly, the local services. Sometimes we advertise, etc. Each study also has a TSC and a DMEC, which is a trial steering committee, and a data management and ethics committee. And they're actually independent committees which oversee all our research, and they're appointed by the funder. But they also have people with lived experience sitting on those panels. And I'm going to come back to some of the challenges around that later on. So if we move up to the parade study on the left, you'll see that's got an additional blue blob called Group Facilitators. And this is just to highlight some of the novel ways in which service users have become involved in the work in Spectrum over time. So in this particular study, this was a large multi-site randomized controlled trial where we were comparing group psychoeducation with group peer support for people with a diagnosis of bipolar disorder. And in this study, all of the groups were co-facilitated by people with lived experience and a healthcare professional. So we were starting to think about, how do we involve service users in the delivery of the interventions as well as in the design and running of the research? So if we move across to the right-hand corner, the REACT study, this was very similar in that the REACT supporters, so REACT is an online toolkit for relatives of people with psychosis or bipolar disorder, and it stands for the Relatives Education and Coping Toolkit. But the online toolkit is supported by people who are trained. So we had some relatives who we trained up to moderate an online forum and to respond to online direct messages. So again, we were trying to think about how can we involve people in the delivery of the interventions. Well, the other thing that's novel about that study is that we ran our surge online. So our service user reference group, the entire study was run online, all the meetings and everything. And I think that was quite challenging, but I'd be happy to talk more about that if that's of interest to people. And then the last study is the Impart Study, which is in the bottom right-hand corner, which was an implementation study. And here the novel PPI aspect was that we employed people with lived experience as the researchers. So the research assistants who were going out to collect the data, and most of the data was qualitative interviews with NHS staff, were people with lived experience. And in this particular study, they had lived experience of being relatives of somebody with psychosis or bipolar, because that's what the study was about. And then the final box along the bottom, which is Spectrum Connect, is a database of people who have consented for us to hold their details because they're interested in finding out more about the research that we do. And that group get involved sometimes in participating in studies, but also very much involved in getting involved in the surges and the other groups I've talked about. Okay, so I hope that makes sense. All of the roles that are here are paid roles, and we use the involved guidelines to work out how much they should be paid. So they all come with a very clear job description and allocated rates of pay. Okay. So we've been working, I think, over time to move along this kind of trajectory from what I would say is a more consultancy kind of approach to PPI to trying to become more co-design, more co-production, and really increase the ways in which patients and public are involved in the research. What we haven't done yet is a patient-led study, and I think this is a really interesting area, which, again, I'm happy to talk about if people want to have that as a point of discussion. Okay, so how well does it work, I suppose, is one question. And we were interested in looking at the impact of PPI on the work that we do in Spectrum. And so we use something called the Public Involvement Impact Assessment Framework. And one of the reasons we use this is because we were involved in designing it. And it actually made me laugh because I was looking at, on Google Scholar for some papers, and there's a paper by Trish Greenall that's just come out, actually, which is a systematic review of frameworks around patient involvement. And one of the conclusions of the study is that most frameworks are used only by the people who develop them. So there's actually lots of frameworks, but they're not very well used. So I'm just putting that as a caveat before I start here. So the Public Involvement Impact Assessment Framework was developed by a combination of a team of us in Lancaster and a team down south in the UK as well. And we used it as a kind of reflective case study on our own work. And I'm going to explain a little bit more about how that goes. And again, if you're already familiar with this, then please bear with me. But if not, it's worth just having a look at this to see whether it could be useful. Okay, so what is PF? So it's funded by the Medical Research Council, and they funded a piece of work which looked at, first of all, an evidence review about the values and impact the values that underpin PPI in health and social care research literature. And the key thing about PF is it's based on the idea that the important thing to do first is to understand why you're doing public involvement, and that actually the reasons why differ for different individuals across different projects. But that's important because it tells you how would you know if it was working, because working is defined very differently depending on the reason that you're doing it in the first place. And the second piece of work was a Delphi survey of key PPI stakeholders around consensus and conflict in PPI. And both of these are published papers which are referenced in the toolkit. So the aim is to help a team to think about how they want to evaluate their public involvement in their own organisation or in the project that they're running. So it's not about how to do PPI, but it is about how to measure the impact. And actually, I think one of the things that's really interesting about it is that as well as helping you think through the impact, what we found was it was an incredibly useful team building exercise because it helps all the members of the team, it requires all the members of the team to come together and really think about why do we think PPI is important. And I think that in the long term, sort of helps overcome some of the challenges that can occur in PPI when people are coming at it from very different angles. Okay, it's not just another caveat on it. It's not a quick fix checklist, this. So this is very much about a process that you work through as a team that requires everybody to get involved. Okay, so essentially, there's 4 key steps to this. So first of all, it's laying the foundation. So working out why you want to assess the impact of public involvement and who should be involved. Developing your intervention theory. So this is about why you think PPI will lead to the desired impacts that you identify. Identifying how the potential context of your research might affect the impact. So for example, have you got the resources that you need in order to be able to do it? And then formulating your specific assessment questions and study design. So, next slide. So just to go through a worked example, in Spectrum, we came up with a number of different areas that we felt were important for PPI. So we had a range of different reasons why we were doing PPI, but one of them was about agenda setting. So we felt that by involving people in, by involving the public, it would change the agenda for what we were doing. So just to go through this, the theory was that public involvement ensures that the research priorities are more relevant to key stakeholder groups. And our key stakeholder groups were patients, relatives, staff, and funders. So ultimately, what we did was our project in the end came up with the idea of comparing the research priorities that were identified by members of the academic team and those in service user roles to see whether there were actually differences, and so that by combining those ideas we were coming to a different place. And we did that using a combination of qualitative thematic coding of priorities and also rating the relevance of our priorities from different stakeholder groups. Okay, so I guess that's giving you an idea about the kind of things that we've been doing, and that's all great, and frameworks are really helpful. But it's, I think in the UK, it's very well accepted that PPI is important, and you know, we're keen to find ways to help do it. But actually, there are still quite a lot of real world challenges, and I just want to share some of those with you. And what I'm really interested in is, are these challenges the same in Canada? And if they're not, have you got any advice for me for how we could solve them in the UK? And I've thought about these challenges in terms of three different areas: so the system, the culture, and the specific role of PPI. So if we start with the system, I think the first part of the system I want to flag is about funders. So all of the funders demand PPI on principle, and actually require quite large, increasingly large sections of grant applications to talk about PPI. But sometimes it feels a bit like the practice of funders is lagging slightly behind the principles. So I just want to give you a few examples to demonstrate this. So the first one is when we apply for funding and we have a co-applicant who's a service user, it's actually incredibly hard to work through the system for them to be a co-applicant. So they have to log on to a system that doesn't make any sense if you're an academic and you're used to using these systems, because they really are quite complicated. But it requires people to have an incredible, first, English has to be your first language because it's not available in any other language. You've got to be quite literate in order to understand the bureaucracy of the system. And you've got to have a computer which has software that will work with quite new software packages. So that's the first barrier. The funders then require you to have a trial steering committee and a DMEC, which I mentioned earlier. And although they're independent review committees, as a research lead, you have to find the people to sit on them. So you have to send emails around and then say to people, will you be on our trial steering committee? But you're then not allowed to have any kind of informal contact with them, and they shouldn't be people you've ever worked with before. So you end up, and this includes the PPI people, so you end up inviting people to sit on these committees, which are highly technical committees. You can't offer them training and support, and the funders don't give them any training and support. And sometimes I feel that these committees end up being quite a negative experience for people in PPI roles. And I think this is changing. People are trying to start thinking about training, but it's been a big issue, I think, today, and something that we need to think more carefully about. Another example is sick leave. So people who have a chronic mental health problem, you know, are potentially over the period of a 5-year research project going to need some time off sick, but actually covering that time is quite a challenge, and the funders often leave sick leave cover to the universities, who aren't delighted about that because it's not covered in the budget. So I think that's another area where we need to make some changes. And then the last one was about authorship bureaucracy. So we recently wrote up a report for a funder report, and the bureaucracy involved in putting somebody with lived experience as an author on that form actually led them to ask if we could just take them off, because they said it wasn't worth it. So first of all, they wanted to use a pseudonym because of confidentiality. They were a relative and they didn't want their son to find out that this was, you know, the work that they've been doing, and they were worried about making their identity known. But it just became very, very difficult. I won't go into all the details. But it's an area where, again, but what really struck me about this was actually that the funders, when we feed back these things, problems to the funders, they're actually incredibly helpful and they want to change the system. And obviously, if they're not sitting on the other side of the desk, they don't understand why some of these might be barriers. So I think the key lesson for me here is we are the system, and actually we need to change it, and we need to share our experiences all the time with the system so that it changes in line with what we need. The other part of the system is employers, and generally in PPI, these are universities and health services. And again, expertise from lived experience is very valued. But one of the challenges we've faced is that there is no career structure for people as they become more and more expert in this role. So it remains the lowest paid expert in the room generally, and it's not clear how people move forward. So the service user researchers in our team have seen RAs come in and to progress up a very clear career structure in the university where they get a PhD, they become a lecturer, they become a senior lecturer, and yet they remain at the same point, and there is nowhere, it doesn't have that career structure attached to it. So I think we need to think very clearly about how we can develop and support people as they become more expert in this role. Okay, so I just want to talk about some of the challenges we have around culture clash. So all research systems and organizations have their own culture. And there are a number of ways in which there's a culture clash between research and PPI. So the first one is professional language. I mean, the number of acronyms in healthcare research is absolutely phenomenal. I'm sure you're all aware of this. And we try and get around it by encouraging people to stop the meeting and ask what it means if we use acronyms, and maybe try not to use them wherever possible. But actually, language is a deliberate way in which professions try to be excluding. So all professions do this, and healthcare is actually no better. But it does make it very difficult to engage people. The other areas are this concept of professional boundaries. So these are very, very rarely made explicit, but they may be very different from the boundaries where the patient has come from. So for example, professional behavior in researchers is often thought to be kind of calm, considered, objective, not too personally involved. But if you're a patient who's been fighting a healthcare system for 10 years to try and get support, and you've actually been trained that you need to be angry, you need to be aggressive in order to get things to change, and it's very personal. So you are bringing things in that are very personal. And sometimes that clash in culture can be really difficult. I think it can also lead to difficulties with identity. So for example, in the Parade study, which I talked about earlier, where we had patients who were co-facilitating the bipolar groups, the qualitative data from talking to them about that role highlighted how they felt really stuck between two different identities. So they didn't feel that they were health professionals, but also the service users in the group clearly didn't see them as part of the service users in the group either. It was almost like they'd gone over to the other side. So there's a kind of identity issue there, which can be difficult for people who are taking on these roles. Research cultures are very target driven, and the targets in research tend to be rewards given for papers and grants, and much less so for how the research is done. But obviously for people in PPI roles, those papers and grants might not be particularly valuable in the same way that they are to an academic for the career structure reasons that I've said. And they're much more interested in how the research happens, what's people's experience of the research, and how do we make sure that the research has an impact. The other issue is poor working practices. So often academics work very long hours, and healthcare staff, and under quite high levels of stress, which has a negative impact on health for all of us. But if you're managing a chronic health condition, this is obviously a particular concern. And then I think the last one is that we underestimate the trauma of working on a condition that we're living with. And just to give you an example of this, we did a study where we did some qualitative interviews looking at the positive aspects of bipolar disorder or living with bipolar experiences. And the research assistant that we employed on that had her own experiences of bipolar. And even though she was researching the positive aspect, so it had a real positive spin on it, she was a fantastic researcher, but when she left the study, she actually left the area of work and said that it's just too much to be thinking all day about something that she's then going home and living with and having to manage. And actually, she needed to work in a different area. So sometimes I think as academics, maybe we underestimate the impact of working in an area that has such personal relevance. So thinking about the lesson from this it's really a question, do we try to acculturate people so that they fit in with the culture? Or actually, does this give us a real opportunity to try to change the culture of research? So could PPI actually be a driver for us to develop a kinder research culture across healthcare that's actually kinder for all of us? Okay, and then lastly, I'm just going to had a few thoughts about the PPI role. So obviously PPI is an umbrella term that actually covers many different roles. And there's lots of enthusiasm to employ people in these roles, but often people aren't that clear about what it is they're supposed to be doing. So some of the things that we've learned along the way to try and help with this are, first of all, trying to create a really clear distinction between PPI and research participants. And that's not always easy, particularly with some kind of participatory action research kind of models. We also try to think about how can we involve people using a really wide range of roles so that we can increase diversity. So rather than obviously not everybody wants to take on a full-time job, and not everybody wants to get involved in writing, so plain language summaries, for example. But there are so many different roles available in PPI and so many different ways in which people can engage. So by coming to groups, by working at a computer, by doing online things. And actually, if we keep that range as broad as possible, then it enhances the chances that we keep diversity among people doing PPI, because at the moment it is definitely dominated by white middle-class people who actually our health services best serve as well. And if we're really going to change health services to meet the needs of underserved groups, then we need to make sure that they're present in PPI. Other things that have been really helpful, having a really clear job description with fair reward. And I think reward isn't just about money, but thinking what makes people feel valued in their role. Training is a big part, and there's a whole another talk about, I'm sure we could get into about this, but what do we train people in? So if we train people in research skills, to some extent that's really helpful. People need to have an understanding about what's happening, but actually, is that really the most helpful thing? Because we're not training them to become researchers, but we want to train them to be able to contribute to the team. So what do people need training in? And finally, that the final lesson is we need PPI at every level of the organization. So in order to make sure that that PPI is done in the right way in all of these different contexts, it needs to come from the top. Okay, so I'm just going to go to the last slide, which is just to have a think about the future. So I think the first thing to say is that we've come a really long way. So when I first started doing research, and this is probably an indication of how old I am, PPI just wasn't a thing. So we didn't do it, and it really wasn't talked about. And now it's in every study to varying degrees. And that's been a really gradual process. And I think the world is a much better place as a result of it, but obviously we're still on that journey and there's still a long way to go. And it's really exciting about the different directions that this could go in. And research is crucial to this development because it helps us to work out how we can keep improving PPI. And this is why the work of places like the BC Support Unit in Vancouver is so important. So I just wanted to flag two sort of areas where I think for me, they're quite exciting questions about the future. So the first is about the methodologies that we use to evaluate PPI. And just to kind of make the point that given that context is so important in PPI, and that we're particularly interested in the mechanism of how PPI impacts on our valued outcomes, I think this is a real opportunity to move away from more positivist approaches to evaluate impacts, such as randomized controlled trials, and to think about the use of realist evaluation approaches that really try and understand what works for who, in what context, and why. And then the second area that I think for me and in the UK is really interesting is how do we take some of the learning from the development of PPI in research to think about PPI in service development and delivery. So the PPI in research feels like it's come a lot further, and some organizations more than others, but generally we need to be thinking about in all our healthcare services, our social care services, where are patients represented within those organizations, and how can we learn from PPI in research in order to improve healthcare systems? Okay, so I'm going to finish there. It's very weird talking to people that I can't see. I don't even know if there's anyone still out there, but never mind. So I'm very happy to take questions, but even better to hear your thoughts or your ideas. And if you can answer any of the questions I asked for me, that would be great.
So thank you for that. So now we're opening up the floor for questions. I'm going to unmute everybody. So please feel free to ask your questions using either the chat box or the microphone, whichever one you prefer. So yeah, let's open the floor up to questions now. Do not hesitate to ask any questions if you have any. Comments are good as well, we'll take those. So feel free to share your thoughts.
Awesome.
I'll get us going with a question, if that's okay. It's Erin here, Patient Engagement Methods Cluster Lead. So Fiona, you rightly talked about healthcare research and engagement of patients in research, or people with lived experience in research, often being done more in people lacking in diversity in your world, often white, middle class people. And I'm just wondering what, if any, methods have worked for you in increasing diversity in the Spectrum Centre, or any lessons you've learned along the way.
So I think it's not something we do well, I think it's the first thing to say, but we have tried with some things. So for example, we used to hold PPI events in the daytime, in work hours, and that obviously excludes everyone who's in a job. So we tried to think about the timing of when we did PPI events. So could we do some things in the evenings? We tried to think about not requiring people to come into the unit, because obviously that just restricts us to a small area. So we tried to run a lot more things online. I do think that there are pros and cons to that. So actually the study that we did, which was an entirely online study, and we ran all our PPI online, what it made me realize was that it's really important to understand the reason that people get engaged in PPI. And I think a lot of the time it's to become part of something and to feel part of a team and to be part of a movement that's making a change. And actually, when you're online, it's harder to create that sense of a team. So it's practically easier, but I think I really hated it. And I think they were people who actually would have preferred something where you come in and you meet the other people. There's a kind of social networking angle to it, and you feel more involved. They felt very distant, and I think that was an issue. How, in terms of things I'm trying to think about, so there's some great work happening around, which not that we've done, but that other people in our unit have done work around people's learning disabilities. So thinking, how do we make things less verbal for people who are non-verbal? How do we involve people in other ways? And they've used things like dance and like theatre and more arts-based engagement projects, which I think is really interesting. It's not something we've done yet, but I think maybe other people have some suggestions.
Hi, it's Corinne Talon here. Can you hear me all right?
Yeah.
Wonderful. So I'm a research coordinator with an organization called Foundry. So one comment to sort of jive off of what you were just chatting about, and then a question as well. So we do a lot of engagement with young people, and that's typically ages 16 to 24, although our organization does work with people as young as 12. And so we have found that the method of engagement can be really important in terms of opening up and creating more diverse engagement. And I'm by no means the expert in this. We have a lot of young people working in the organization that would probably provide better answers, but things like online chat, virtual interactions, and then even options for text messaging and having conversations via instant messaging have actually been helpful in sort of getting different types of engagement and different young people involved in the engagement process.
That sounds great.
And then just a question as well. I apologize, I'm interested to learn more about your organization as someone who's hoping and trying to support building more formal structures to support our engagement process in research, but in other departments as well. I'm just wondering if you could, without going into too much detail, provide some context around how long it took you as a center to sort of set up some of the structures that you were discussing in terms of those patient engagement. So you mentioned you have an advisory group with every project you do, and just wondering what that process was like and how long it took and how you shifted that culture as well.
So our team's been running for 11 years, and when we were funded, it funded two academic posts and a service user researcher post, and we were very clear that that's what we wanted the funding envelope to have in. So we were really lucky, because that is quite unusual. So that there's always been somebody who's, and that role was quite explicitly to facilitate PPI involvement. So the structure of having the advisory panel and the core team member was there from the beginning. But then each time that we set up a study, I don't know if it's the same here, but in the UK, the NIHR have now started to give you a small pot of money, about 350 quid, to do PPI work when you're developing a grant application, because that used to be a real challenge, that you didn't have any money, so how do you involve people? So you can apply for this small group and a small amount of money, and that can allow you to invite people in to have a really early chat about, is this a good idea? Like, do you think we should be researching this? So that we're not spending a long time trying to get funding and then, getting the PPI people involved, and they say, actually, I don't know what you're doing that for. It's a load of rubbish, kind of thing. So that brings people who are interested, and then from that group we invite them to stay involved in the project if it's funded as the reference group. So that's kind of so each study we do it as we apply for funding. Does that answer your question?
That's really, really helpful, because I think that's part of the challenge is sometimes in our situation the funding comes at the time of the project starts, and then to do that foundational work, there's not always the sort of the time or additional funding that's required to do that as part of the project process. And that's not the case for every application, but I think we're still working with some of those challenges. And I think that comes back to the piece around, the funders and the systems changes and working to be part of the change.
Exactly. And actually, that is one of the changes that the NIHR made based on lots of feedback from people saying, how are we meant to put in a good PPI? You're saying you want good PPI before we put the grant in. How do we do it? And so to be fair to them, they listen and they change, which I think is brilliant, because I can't say that about all organizations.
So do we have any other questions or comments?
Can you guys hear me? This is Bev. Hi, Fiona.
Hi, Bev.
So you talked about, one of the things you talked about was PPI in positions of leadership within organizations. And I think going back to the previous person who was talking around funders and having them understand the needs of PPI and how to make those changes at that sort of level, for lack of a better word. So what does PPI in leadership in organizations, what does that mean to you? And is that occurring anywhere in the UK?
So I think in so for example, in the university, we now have, you know, at the very senior level in the university, we have vice chancellors of research and vice dean, and we actually have one now for public engagement. So that's not specifically patients, so it's any kind of public engagement for the research across the university. But within that comes patients. So for our health faculty, the work that we do is in that organisation. But that is a very recent thing. So that's someone who's been appointed, I think probably at the most 2 years ago. And I think it's a really good change. And before that, the service user researcher in Spectrum really struggled because above that was the same agenda. So a lot of help things happen in Spectrum. If we needed to operate in the wider system, that became a challenge. So I think whether other universities have also done the same, I'm not sure, but certainly public engagement is much more on the agenda at a university level. I'm sure it's the same in UBC. So I think it's partly about getting that patient involvement within that agenda so that it kind of, there's links and there's good communication. In healthcare services, so I know that our 2 local NHS trusts have now got patient partners on the trust board. And actually one of them was, I think this was a brilliant idea. At the start of every senior board meeting, they had a patient come in from the trust and just tell their story about what kind of care they'd received from the trust. And it was about making sure that there wasn't this big disconnect between people in leadership making decisions and people on the ground. How much power the PPI partners have on those, I don't know, and I'm sure it's still evolving, but there's certainly a recognition that there shouldn't be levels of an organisation where there isn't user involvement. And users could be whoever the users are for that organisation, whether they're patients, whether it's the public, whatever. Does that answer your question?
We'll take that as a yes.
Yeah, thank you.
Do we have any other questions or comments?
So can I ask a question?
Hello.
Hi, sorry for being a bit late. Sorry, Sterling Bryan, the Scientific Director at the Support Unit. So just the point that you were making about almost like the learning for the healthcare system from the experience of PPI in research. And I guess it's a two-way, potentially a two-way sort of learning opportunity. My sort of sense is that what we're trying to do in research might actually be quite different to what is typically done as PPI in service sort of delivery. I mean, and I may be off base on this one, so I don't know, but I mean, I'm seeing a lot of work on sort of like advisory committees that people have, or quality improvement projects where there are people coming in to provide advice in the service sort of sector. Whereas in the research, we're like trying to do it more as like co-design. So it is fundamentally, I think, like what we're doing with patient-oriented research here is trying to bring that sort of voice early on and to be true partners, like equal partners in that research process. I'm not sure I see that as much in the service delivery side, or am I just not seeing that?
Do you mean you don't see it happening, or you don't see the purpose of it?
Oh, no, I don't see it happening.
Yeah, no, and that was my point really, right. That maybe the service delivery side is behind the research side, because I mean, you know, with healthcare services, it doesn't make any sense to design them without asking people what they should look like, you know, be co-designing them right from the beginning. Yeah. So I totally agree. I think the agenda's moved forward a big leap from, there was an earlier slide that had a kind of consultancy right up to patient-led sort of arrow. And I think that the service delivery and design is still at the consultancy phase. And actually it needs to, I think the research agenda's moved forward, but it hasn't in service development.
Okay.
Any other questions? Give it a few more seconds.
Can you hear me?
There we go. Yes.
It's Barb.
Hi, Bob.
Sorry, I came in late, so I've missed much of the conversation, but it was of interest to me. So hopefully I can see your slides in the future. My question is along the lines of Sterling, was it, that just asked the question.
Yes.
As a patient partner and somebody that has done research in another field, science, I sometimes question participation because there is no feedback after the participation of the patient partner. How did they feel? Did they think it was useful? How was it used? How was it carried forward? And as Sterling mentioned, I participated in various aspects, so part delivery, part organization, part event planning, etc. And you can do all that, but are we now just bringing as patient partners as consultants that we used to pay for that sort of information? So I was thinking back to when I started my career, we would pay a consultant to come in and do event planning or whatever. So patient partners can do that now also. Many of them are retired. They've had businesses, careers, etc. I know you get all this already. So what are we really looking for from them? And do we acknowledge that level of expertise that's coming in? It's not just about the research, and they may have a medical condition or whatever, an experience there, but they're also bringing that expertise from another part of the world, and whatever we need to do to make the world work, as far as events, as far as advertising, as far as paper writing, etc. So I don't know that we've really looked at the full scope of patient-oriented research, because we have a lot of spin-off of their talents that aren't formally recognized. Does that make sense?
So are you saying that people come with a whole range of skills that actually get used in the research in a bit sort of hidden? Is that...
They're not hidden. It makes them more valuable to the research by the skills that they bring from other places in their life, not just the medical side of it. And they may bring in research skills from another area that can be cross-pollinated, sort of thing, that maybe medical research hasn't really looked at it that way. So it's not just bringing, because I've got this condition or had experience in this area, it's their whole life experience that comes in, as it does with the researchers now doing that, right? So it's not just patients doing that, it's every human or even animal or whatever, it's all bringing something else to it than just the specific problem that we tend to focus on in research, right?
Yeah.
Because we have to do it that way, right? To say we've actually tested this and here's the results, and then the hoops you jump to get a paper published. So yeah.
Yeah, no, I totally agree. And I think one of the early slides was about sort of this dichotomy that we create about patients and researchers. And actually, it's all people who come to the table with such a range of experiences and different skills. And actually, how do we best make the most of that, rather than giving people a label that might confine how they get involved? So we did have the experience of a patient partner who was a professor of statistics at the same time, and we were desperately running around trying to find a statistician for this project. And he said,
yeah,
I can help do that.
well, this is it. And they enjoy doing that. As anybody that works in research, you can't help yourself, right? Like you just give, right? And make it work and have that curiosity with you. And so sometimes we shut down the curiosity of the patient partners because they're not from that field. And I know in my area of research, you had to leave yourself totally open all the time, because you're always surprised and where a piece of information or just a different angle of looking at it came from. And it often wasn't the researchers.
Yeah.
So, the formal researchers on the project, it was from outside. So yeah. So how do we make patient-oriented research a little more open from the formal process we have to follow as scientists in the scientific world? And are we missing those nuances while we're focusing on our science and doing it a certain way? I don't know if that makes sense.
It does make sense. I mean, I think one of the things is about the methodologies we use. So some methodologies are more open to people sharing ideas and maybe are a bit less rigorously controlled than others. So maybe it's about ensuring that we use a range of different methods. So, I mean, things like participatory action research, where maybe people can be part of the research process and part of the findings, so that they're working throughout the project to adapt it and to think about where it goes next in light of the findings. So I don't know whether. And the other thing I think that we've started to do in Spectrum, which I think is really helpful, is when people become involved, is ask them a bit more about who they are and what their skills are and what exactly they want to get out of being involved. Because I think also we have lots of assumptions about the role people will have, and we've got an idea about how we think it should work, but actually it's different for everyone, and making that explicit at the beginning, I think, can be really helpful.
Yes, and I guess too, some projects I've worked on, you can make the project run well, you can come up with a good presentation, you can have a good audience, and it seems successful, but the patient partner's questions haven't been answered out of that process. Yeah. So again, we all get sucked into, this is the presentation, and we have to meet our work sort of checklist. But then in that process, sometimes the patient partner, why they came in to help was to learn something, but they never did get to learn that because there was so much focus on the steps that we must do because this is our workplace. And so have they checked in with the patient partner? Did they get their questions answered about that specific topic? And that doesn't usually happen. You can still have a successful event, but the patient partners are walking away going, actually, we didn't get the information we wanted out of this. So yeah, just that check-in at the end, I guess. Yeah. And you were sort of as alluding to that when you're answering the question before I butted in here. And I think Sterling was the process afterwards, and is there patient partner participation in after you finish the research and you're bringing it out into the community or whatever you're doing with it? Is there another check-in with them? Did we get it right? And I mean, researchers do that amongst themselves all the time, but we don't necessarily go back to the patient partners that were involved and go, okay, it's been a while, did we get it right? Did we answer your questions having this? Yeah. So just those sort of thoughts. Yeah, and, I'm amazed, and I'm really privileged to be part of this movement so far. And I'm impressed with the people that I've worked with. But since we're throwing out questions and going down the road, those are my thoughts. Thank you.
Thank you. I think that's a really good point, actually. And part of it is about, we talked about not having funding at the beginning for PPI. Actually, when research grants come to an end, they come to an end very quickly and everybody disappears because their funding stops. And so to do that follow-up work, I do agree with you totally that we need to do it. I think it's thinking through practically how do we do it when the project's gone and the staff are gone. And actually, we have failed to follow up on it. So, yeah, I think that's a really important point. Thank you.
Thank you for your time.
Thank you. So that's all the time we sadly have for today. So I'd like to thank Dr. Fiona Lobban for taking the time to present for us. And I'd like to thank you all for coming and participating in this. So please, as stated, this is being recorded and will be available on our website. So please check in a couple of weeks so you can share with your friends and colleagues. So thanks, everybody. Have a good day. Bye.
Bye.